This works, right?
Yes.
Here.
Yeah.
So, good evening, everyone, and welcome to today's wonderful evening. Jugular venous pressure is the next important topic. So, what do you have here? You can give me a pen and paper.
Yeah.
That's more easier.
Yeah.
Good to see one online classmate. So, can you please punch his voice loud and clear for all of you, doctor? Right. So, typically, we need to know where is the systole and where is the diastole. So,
This is the time he comes down.
mm, so you should know where the systole begin, where the diastole begin, and when the ventricle is undergoing diastole, it has got 3/1/3.
No.
It has got 3/1/3. So what is first 1/3 because of? Atria is full with blood
Rapid fit.
and it is filling into the ventricle, which is empty, which is first 1/3. Atria are at higher level than ventricle. That's the reason second 1/3.
Yeah.
And last 1/3 is because contraction of the atria. So let us start from there. The last 1/3 of the diastole typically will lead to the contraction of the atrium and rise the pressure in the jugular venous pulse, and that is called as A wave. Then the blood fully entered into ventricle. End of the A wave is the last 1/3 of the diastole ending and the beginning of systole. And during the systole, the atrium is relaxing. That lead to
Drop in the
X descent. And during that time, the ventricle is undergoing systole. So the pressure in the ventricle increases.
Yeah.
That will cause a slight rise of the pressure in the atrium, and that lead to in the X descent a small spike which is called C wave.
Okay.
So first you have the A wave, then you have a small spike in this descent which is called as C wave. Then you have the ventricle. Then you have the atria
Yeah.
getting filled with the blood from the great veins, and that will rise the pressure. Then the ventricle systole is over and the valve opened. Then it flows into this.
Yeah.
And that is basically called as
Widest.
Y descent. So it is the blood that filled into the atria that lead to V wave. It is the contraction of the atria that lead to A wave. And it is the relaxation of atria that lead to X descent.
Yeah.
And it is the pouring of the blood in the atria into the ventricle that causes the atrial pressure to fall down, which is called as Y descent. Just if you know this order, you know everything. So wave A, atrial contraction. When does it happen? During diastole. Last one.
Last one.
Wave C is the tricuspid bulging. That time ventricle is in
Systole.
systole. Then, so there is a X descent which is because of atrial relaxation. Atrial relaxation. Then Y descent is because of the RA emptying into the RV. So what lead to a prominent A wave?
Any pressure-
Whenever the
increased pressure in-
atrium has to contract against a stenotic tricuspid valve,
Okay.
or whenever the atrium is emptying into, contracting and pushing blood into right ventricle.
Yeah.
Any right ventricular hypertrophy or pulmonary hypertension, any of them can lead to a prominent A wave. Atrial fibrillation lead to absent A wave.
Okay.
And if there is any complete heart block, then the atria are hitting against a closed valve that lead to canon A waves. So only what lead to prominent V wave? First of all, V wave is because of
V wave is because of filling in the atria.
filling of the blood into the atria. Suppose if it is getting filled both from the great veins and also regurgitant blood of tricuspid regurgitation together will cause a prominent V wave. Then what is Kusumal sign? Whenever there is a constrictive pericarditis, then the atria won't get filled. And normally during inspiration, the great veins drain into the atria
Yeah.
and they collapse.
Yeah.
And they won't collapse. So non-collapse of the jugular veins during the inspiration is called Kusumal sign positivity. Surely whenever there is any constrictive pericarditis,
Yeah.
there is a thick pericardium around the
Ventricles.
atrium and ventricles.
All.
So because of the thick pericardium, what will it do? It will push the blood very rapidly from the atria into
Ventricles.
the ventricle. Ventricle is the one which is expanding.
Yes.
Atrium is the one which is contracting,
Yeah.
unloading. And that unloading become accentuated by the thick pericardium around, and that lead to the development of
Rapid Y descent.
rapid
Y descent.
Y descent. Then if there is any cardiac tamponade,
Yeah.
there is a diastolic collapse of the ventricle that won't let the atrium to
Push the blood in.
push the blood easily into
Ventricle.
ventricle. That's the reason absent Y descent is a feature of cardiac tamponade. But
Prominent Y descent
a-
is constructive.
a prominent
Y descent.
rapid Y descent.
Yeah.
Prominent Y descent is a feature of constrictive pericarditis.
Absent is in tamponade.
Correct. It can be absent or slow. Suppose if tricuspid stenosis is there also, the Y descent will be slow, is what you need to remember. Right? That's all about JVP. You are ready?
Yeah.
Because that is one question who will be looking at you and smiling.
Yeah.
And if you simply know why A wave, why C wave, why X descent, Y descent, V wave, and everything,
Yeah.
just situationally you need to correlate and
Yeah.
answer. Right, doctor? Then comes congestive heart failure. What is the most common cause? Ischemic heart disease. Signs of right heart failure? JVP, elevated pedal edema, ascites, hepatomegaly are all right.
There's no plural.
Whereas dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Why paroxysmal nocturnal dyspnea? In the night time when you lie down and sleeping, a lot of the right-sided blood will move into the left side. And that lead to more, because the left heart is not able to pump, no?
Okay.
So that lead to congestion in the lungs, leading to edema. Right night when you sleep, all your right side circulation move towards left and left overload will occur.
Okay, sir.
That's the reason after sleeping you get paroxysmal nocturnal dyspnea. Why paroxysmal? The moment he is short of breath, he will sit. Once more it will set. Once more he'll go to sleep. Once more the dyspnea. That's called paroxysmal nocturnal dyspnea. Then it is called high output and low output failure. Can the online students can punch? Is the voice loud and clear? Now, doctor. High output failure and anemia, thyrotoxicosis, AV fistula, beriberi. All these are hyperdynamic circulations. The moment the heart pumped, right, it will quickly return. If anemia is there, there is no resistance for the blood, no, because viscosity is low.
Okay.
So it will rapidly come back to the heart. Other than it.
Sugarless.
Thank you. Good. Today is what, 18th?
19th.
19th.
18th.
18th.
We started almost on March 18th.
Yeah.
April 18th, May 18th, June 18th, July 18th. 120 days
Yeah.
of saga with 1/3 of the year 2025 with Viraj. But the most memorable part of the year. So I exhausted 120 cups of tea and coffee. So now high output failure ante anemia, thyrotoxicosis, AV fistula and beriberi.
Any hyperdynamic states.
Low output failure
Takkuva.
causes ante ischemia, hypertension, cardiomyopathy, they all cause.
Okay, sir.
What characterizes a systolic heart failure? If there is a reduced ejection fraction, less than 40%, or if there is any dilated cardiomyopathy also, and the alcoholics, most common cause, that lead to development of systolic failure. Diastolic, and it is not ready to get filled because of the thick LV, which can occur with hypertension.
Okay,
So that is the reason normally if impaired filling, so HF with the preserved ejection fraction is the feature of diastolic failure. So how do you recognize diastolic failure? There is a measurement called NT-proBNP. NT-proBNP. BNP is brain natriuretic peptide. The moment the atria are not getting filled, they are getting, right ventricle is not getting filled, the pressure in the right atrium will increase, it gets stretched and produce the brain natriuretic peptide.
Okay.
So BNP, in fact, not 100. 100 is wrong. 450 is normal. And anybody who has got a 5,000, 6,000 value has got a diastolic failure. अगर चैलेंज एंटी 2D इको में कुछ भी नहीं निकलता.
Okay.
2D इको में आपको इजेक्शन फ्रैक्शन नॉर्मल दिखता.
Yes, sir.
So how do you make a diagnosis if the ejection fraction is preserved? By doing NT-proBNP. Now, if you look at the chest X-ray, what are the features of congestive heart failure? The pulmonary veins go prominent on the apex of the heart. That's called cephalization. Head and is cephalic, no?
Yes, sir.
Cephalization of pulmonary vasculature, otherwise called reverse mustache sign. Mustache kinda together. Reverse mustache sign is called the
Civilization.
chest X-ray finding. Similarly, you find cardiomegaly, curly B lines. ఇవన్నీ కూడా ఎక్స్రేలో చూడాలి డాక్టర్. చెక్ చేసుకోండి. S3 gallop is a feature of systolic failure. Diastolic failure is indicated by S4 gallop, which is due to the hypertensive, thickened, hypertrophied heart. Hypertrophied heart is an indicator of
Hypertrophied heart
S4 gallop,
S4.
diastolic failure, right? Now, what is the best initial drug to treat? Loop diuretics
Because of
to
congestion.
decongest pulmonary circulation, dyspnea to vasthe. Long run lo what you need to give? Beta blockers, spironolactone, ACE inhibitors.
Ventricle.
They will all improve the mortality.
Mortality.
Which drug is contraindicated in systolic failure? If you give calcium channel blocker, it's a negatively inotropic agent like verapamil.
Okay.
So if you give a verapamil, then that can worsen. Already heart is unable to pump. ऊपर से जाके आप उसके सर के ऊपर एक नारियल डाल दिया. So that's a reason verapamil is contraindicated. So any congestive heart failure patient under treatment of you,
Yeah.
his CHF findings are not improving,
Yeah.
like pedal edema or anything. Look at his medications. In that, if you find cilindipine, amlodipine,
Yeah.
they're all what?
Pond.
Calcium channel blockers.
Yeah.
So verapamil also is calcium channel blocker. So they will actually worsen the
Congestive heart.
systolic CHF, not diastolic.
Okay.
Marchpodiri.
Right.
Then we give cardiac support therapy. If the QRS is more than 150 millisecond and there is a risk of ventricular arrhythmias, so that's the reason we need to put intracardiac defibrillator. Now, similarly, advanced therapies which will help the heart to pump the blood, like CRT, cardiac resuscitation, is done by when the NIHA classification, New York Heart Association classification of the CHF is between 3 to 4,
Okay.
right?
For
Now,
advanced grades. The advanced grades, advanced therapies.
correct. So definitive treatment is cardiac transplant. So in the main point, what examiner will ask: cephalization, curly B lines, cardiomegaly, S3 gallop, S4 gallop, BNP roll. Konni points.
That's
ఇందులో కూడా only ఒక 4-5 very specific points for the entrance,
Okay.
Yes.
right? కాకుండా మిగతా ఎందుకు డిస్కస్ చేస్తామంటే అట్లీస్ట్ ఒక కాన్ఫిడెన్స్, నో,
Yeah.
you know, everything is confidence, doctor.
Yeah.
Now QT prolongation, when do you call QT prolonged? QT is considered to be prolonged if it is more than 450 milliseconds. Corrected QT. What is corrected QT? QT by square root of RR interval, because QT interval is dependent on heart rate.
Okay.
That's the reason we need to correct it to the heart rate. And the correction formula is QT interval divided by square root of RR interval will give you corrected QT. That is normally less than 420 milliseconds.
Okay.
You call prolonged QT if it is more than 450 in case of the men and more than 470 in the case of
Women.
women, is what you need to remember. So I was giving interview in the GTV. Suddenly the anchor asked,
Yeah.
is hypertension more common in men or women?
Mhm.
I was not sure.
Men, I guess.
So whenever you are not sure of
Yeah.
answer, no,
Yeah.
you should tell. It's a very good question. Huh?
Yeah.
Except in entrance exam. After coming out in entrance exam, you ask,
Yeah.
how is the paper? Oh, a lot of very good questions came. That means he didn't answer. So I said, it's a very good question. You know, pregnancy, more plasma volume.
Yeah.
By mistake, I was about to say probably. Probably is not acceptable. I'm an
Right.
authority there.
Right.
GTV, entire country
Yeah.
watching.
Yeah.
So I said that, women, who else? But I did not say
Yeah.
have high BP.
Yeah.
That is inferred.
Yeah.
So women will then think women will have less, men will think men have less. Anyway,
Yeah.
after you join graduation, I'll tell how to answer in the water rounds.
So prolonged QT is hypocalcemia, right?
Prolonged QT is hypocalcemia, shortened QT is hypercalcemia. Very good. And once QT is prolonged, there is a risk of polymorphic ventricular tachycardia. And కొన్ని small QRS, కొన్ని big, కొన్ని small. So it looks like a
Spindle shape.
spindle
Okay.
and lead to cardiac death. That's called
torsion.
torsidis
Torsion,
depointus.
yeah.
ఒకసారి మళ్ళా you look at the ECG of torsidis depointus.
Just
The
come
most
first.
common congenital type of prolonged QT interval is Romanov syndrome.
Ward.
Ward syndrome. It is autosomal dominant and is purely underlying cause is cardiac. Then, if there is a congenital deafness along with prolonged QT, then that is called as Jervell and Lange-Nielsen syndrome, which is autosomal recessive. Commonly, they will ask only QT prolonged, Romanov Ward. With deafness, Jervell Lange-Neil.
Yes.
That autosomal dominant.
Yeah.
This is recessive. Recessive are always dangerous.
Okay.
Consanguinity
Yeah.
is associated with autosomal recessive.
Yeah.
Yes.
Early to appear in life is autosomal recessive.
Oh.
And 100% mortality is
Recessive.
autosomal recessive. Variable penetrance and variable expressivity is the feature of autosomal dominant. What is the variable expressivity? 3 brothers have.
Yeah.
Same autosomal dominant gene. One is good and became IAS officer.
Okay.
The other became police constable. I mean, different levels
Yeah, express.
of that's called same gene expressing differently is called expressivity.
In
Penetrance.
dominant.
Huh?
In dominant.
Autosomal
Yeah.
dominant లో అట్లనే ఇంకొకటి ఏముంటది వేరియబుల్ పెనిట్రెన్స్ పెనిట్రెన్స్ मीन्स एक सैकड़ों लोगों जिसको वो एबनॉर्मल जीन है उसमें एक पॉपुलेशन में 20% को ही इफेक्ट दिखा अनदर पॉपुलेशन में 40% को दिखा दैट्स कॉल्ड पेनिट्रेंस इज ए पॉपुलेशन टर्म
Okay.
అది గుర్తుపెట్టుకోండి దెన్ వాట్ ఆర్ ద ఎలక్ట్రోలైట్ కాజెస్ ఆఫ్ prolonged QT? Hypokalemia, hypomagnesemia, hypocalcemia, all hypos.
Yes.
Similarly, class 1A group of antiarrhythmics like quinidine, and class 3 are sotalol. Sotalol is potassium channel opener. So once more, all antiarrhythmics, what is their
Classes.
mechanism of action? 1 or 2 side effects. Will they affect the PR interval or not? Ado sodindi.
Right.
Open చదవండి.
Right.
Similarly, haloperidol, antipsychotic, commonly used. Serenates is the tablet name. So haloperidol, tricyclic antidepressants, SSRIs, lithium, all of them can lead to development of
QT.
QT prolonged.
QT prolongation. Similarly, macrolides, fluoroquinolones, fluconazole, ketoconazole, ondansetron, Jofer tablet also can cause. Domperidone, lot of times पैंडी देते मुझे बहुत डर लगता है पैंडी देने को क्योंकि वो डी डोमपेरिडोन जो रहता है पैंडी में उसके वजह से भी क्यूटी प्रोलॉन्गेशन आके एरिथमिया में जाके मर सकते किसी को मालूम नहीं क्यों मर गया राइट
Yeah.
elderly grandpa's death has many contributors right
Yeah.
Without doctors why how will people die doctors should be there we should only read half of the high yield facts remaining half patient will go now bradycardia basically prolonged QT can prolong repolarization T wave ఉంటుంది కదా అది లేట్ అవుతుంది కదా QT prolong ఉంటే
Yes.
దాంతో కూడా కొన్నిసార్లు బ్రాడికార్డే రావచ్చు నాట్ నెసెసరీ ఆల్వేస్ టార్సిడిస్ టెకికార్డియా అని కాదు రైట్ దెన్
Postpone.
acute treatment very important IV magnesium sulfate
Okay.
for QT prolongation అది గుర్తుపెట్టుకోండి ఫేవరెట్ క్వశ్చన్ అండ్ congenital conditions Romanov syndrome వాటన్నిటికి it is the beta blocker and intracardiac defibrillator We don't know when will arrhythmia come. So this defibrillator will recognize and fire.
Yeah.
And how do you measure? Where do you measure? We measure in lead 2. Lead 2, ఎక్కడి నుంచి ఎక్కడ connect చేస్తే lead 2? Right arm to left leg is lead 2. Right arm to left arm is lead 1. Left arm to left leg is
Lead 3.
lead 3. So lead 2 is exactly the way the cardiac rhythm is passing. It's called rhythm lead. That is the place where you see the QT interval, right? Or V5, V6, which are the left-sided leads, right? So what is that formula called? Bejet's formula. Corrected QT interval is QT divided by square root of RR interval is what you need to remember. So we should avoid class 1A and class 3
Antiarrhythmics.
antiarrhythmics. बस एग्जाम में भूत के जैसे आके बैठेगा QT prolongation. Now you are king. Are you ready? Good. So nice. Thank you, sir, for such conceptual teaching. What do you say? Mithuna is not agreeing. क्या है सर ये फटाफट एक टेबल में कार्डियोलॉजिस्ट बना रहे हमको 25 टेबल लगेगा बेटे बिफोर कार्डियोलॉजिस्ट. See, always many missions of life, they look what you call big, great, difficult to achieve. But ఏంటంటే you should know the gist. Entrance को गए तो it's not the knowledge. What they test is the pattern.
Okay. Yeah.
The one who knows the pattern is the winner of entrance exam. Remember that. Not necessarily the knowledgeable one. इनको पैटर्न मालूम है. 3 साल से पैटर्न के साथ खेल रहे. थोड़ा पढ़े तो उसको, if you fill the little flesh into that skeleton called pattern, you will create a nice outcome. No worries. Are you fine? Are you feeling
A little warm, yes.
Switch on the AC.
AC?
You're not feeling warm, sir.
ఇప్పుడు ఏసీ అయితే నాకు తుమ్ములు వదిలేతే. బట్ పర్వాలేదు, పెట్టండి ఎందుకంటే his royal kindness is
No,
not
sir. We'll shift places. I'll tell you that.
Yeah.
Okay.
Okay.
అంటే కుట్టేదాని కుడివైపు ఏడ్చేదాని ఎడం వైపు ఉండద్దట.
It's directly.
You know that? जो सुइंग करता उनके राइट साइड में नहीं रहना, जो रोता है उनके लेफ्ट साइड में नहीं रहना.
I don't know, sir.
आप राइट में हैं. यू आर नॉट टेलरिंग, नो? हाँ. Now, shock में most common type is hypovolemic, and जनरल का shock లో tachycardia ఉంటుంది. Only one where you have bradycardia, neurogenic shock, and anaphylactic shock is because of IgE mediated. Then obstructive shock क्यों होता है? When there is a pulmonary embolism, tamponade, tension, pneumothorax, they all lead to obstructive. And how is the central venous pressure? If it is hypovolemic, low CVP, low pulmonary capillary wedge pressure, and high systemic vascular resistance. Because of the hypovolemia lead to vasoconstriction reflexly.
Yeah.
Whereas in cardiogenic shock, heart is unable to pump. So back pressure in the jugular vein will increase.
Hi.
This side left atrium increase. So left atrial pressure is reflected by pulmonary capillary wedge pressure. So high CVP, high PCWP, low cardiac output is equal to
Cardiogenic.
cardiogenic shock is what you need to remember. How do you know that there is an impaired perfusion? Serum lactate more than 2 millimoles per liter. And what is the best way to treat? It is the crystalloids, not the colloids. Colloids are albumin, avanni colloids. Ringer lactate, normal saline, DNS, they're all crystalloids. Are the ones which are preferred. And if it is a septic shock, there is an intense vasodilatation, pulse pressure is wide. Whereas in the case of the cardiogenic shock, there is a narrow pulse pressure in hypovolemic and cardiogenic. Septic shock is called distributive shock.
Yes.
There your pulse pressure is wide, is what you need to remember. So that's all. We're done. Beyond it, imagine based on this funda.
Yeah.
Then comes mitral stenosis. Most common cause is rheumatic heart disease. Most common valvular disease typically happen. Mitral stenosis is because of rheumatic heart disease. Within rheumatic heart disease also most common is MS.
MS.
Normal mitral area 4 to 6. Severe mitral stenosis if it is less than 1 centimeter square. And what is the hallmark of MS? Exertional dyspnea. Whenever mitral stenosis is there, the pressure inside the left atrium increases, unable to
Yeah.
push into the left ventricle.
Yeah.
LAP, left atrial pressure increases. That will in turn reflect on pulmonary capillaries. That's the reason pulmonary capillary pressure will increase. So that is what we need to basically remember.
That's
So-
capillary wedge pressure only, sir.
Pulmonary capillary wedge pressure is an indicator of
Left-sided.
the left-sided, that is left atrial pressure.
Yeah.
Right atrial pressure is reflected by your jugular venous pressure.
Yes.
Clear?
Yes.
So, what is the classic murmur? Mid-diastolic rumble at the apex. And there is an opening snap. When does the opening snap occur? When will mitral valve will open? The mitral valve typically opens after the
S2.
second heart sound. Mitral valve will opens after the closure of the
Nephew, sir.
yeah.
Nephew, sir. Yeah.
So yeah, అది ఎప్పుడైపోతే 6 కా
Yeah. అడుగుతా.
నో వరీస్ కానీ మా వాయిస్ అంతా టాప్ లేచిపోతుంటుంది పర్లేదు కదా
Yeah.
I sound like a Christian preacher. Hallelujah. A touch will cause you to crack the top rank in NEET PG. All right. So, yeah, good to see 4 online classmates.
Medicine is best.
But I mean, remaining things I don't teach well.
No.
That's what doctrine is saying. Medicine is best. Okay.
Sir is best for medicine.
Originally, that was the brand name, but 19 subjects teach करने वाला कोई 2 दशाब्द तक कोई भी नहीं था. बाद में अभी बहुत लोग हैं.
Yes.
So, opening snap typically occur when the mitral valve opens. When will it open? After the closure of aortic valve.
Yeah.
So that will lead to second heart sound.
Yeah.
So second heart sound खत्म होने के बाद जो होता है वो diastole होता है.
That is closure of aortic and
Pulmonic valve lead to S2.
Yeah.
After
S2
that,
valve.
the mitral valve opens and blood flows from atrium into ventricle.
Yes.
इसलिए S2 के बाद
Opening snap.
S2 के बाद diastole और systole?
Diastole.
Diastole. S1 के बाद
Systole.
systole. You'll remember, right?
Yes.
Yeah.
Lub S1. S1 के बाद systole.
Yeah.
Lub systole, dub diastole. Lub systole, dub diastole. Ante. So opening snap. Then between this opening snap and the S2, ये दोनों के बीच में इंटरवल कैसा है? That is indicator of the severity of mitral stenosis. Kaiku S2 close हो गया. Aortic valve.
Yes.
तो mitral valve तुरंत ओपन हो गया.
Shorter.
मतलब
Shorter.
नहीं. कौन ओपन कर रहे हैं उसको? Mitral valve के पीछे left atrial pressure is deciding
Yeah.
how fast it will open.
Yeah.
Suppose if the mitral stenosis is very severe,
More pressure in the left atrium.
left atrial pressure is high, and the moment aortic valve closes,
This
top it will open. That's the reason between the S2 and this opening snap, the shorter the distance, immediately after S2, if the opening snap occurs, then that means there is a very high left atrial pressure behind the mitral valve, which is an indicator of
severity of the MS.
severity of MS. అర్థమైంది నాలుగు కదా?
లే అయింది సార్
లేక
అర్థమైంది
లెక్క.
సార్ యూ కెన్ క్విజ్ మీ సార్ అలా ఆన్సర్
ఓకే
Quiz.
Yeah.
ఓకే ఇప్పుడు కాదు కొంచెంసేపు అయినా క్విజ్
ఓకే
Sir, ఒక్క question
ఇప్పుడు అడిగితే మజా ఉంది చెప్పేస్తాడు
Bulb egg. తెలుసు.
నన్ను ఇక్కడే రాసింది కదా.
అచ్చా సరే
సో మా అభినవ్తో కదే గొడవ. తక్కువని చెప్తాడు ఆన్సర్. అబ్బా అర్థమైంది ఏమనుకుని మళ్ళీ పోతే వాట్ వాజ్ దాట్ అని అంటాడు. Now, if there is a loud first heart sound, it is a very early sign, mitral stenosis. Between opening snap and all that, first to start with, it is loud S1.
All the stenosis will be loud, sir. They'll give us loud.
Not
sound.
necessarily.
Except
Pulmonic
calcified.
stenosis. Pulmonic stenosis is soft.
Okay.
Aortic stenosis, mitral stenosis is loud.
Okay, sir. The left-sided ones are loud.
ఒక రకంగా చెప్పొచ్చు.
Aortic
Tricuspid
and
stenosis, I don't know, but PS అయితే soft.
soft. Okay, sir.
Now, loud S1 is a early sign, but if that get calcified valves over a
Soft.
period of time, then they can't make a loud S1 when they S1 is the indicator of closure of the valve.
Yeah.
So a stenotic valve, when it closes, no,
Yeah.
it makes loud sound.
Yeah.
But if it is calcified, no more.
Unable to close that.
Similarly, if the MS is also with regurgitation, then also
It will not.
when it is closing, there is a regurgitant stream, no? So it is like in the water, it is closing.
Okay.
So that is the reason it leads to
Soft.
softening. Then what is the most important reason a patient of MS will die? The moment the left atrial pressure is high for a long time, atrium get dilated and the dilated atrium will throw atrial fibrillation. The moment atrial fibrillation is there, that is where the death of the patient is marked. I mean, downgrade will start
Yeah.
from there. Then, because of the atrial fibrillation, the blood gets stagnated and
No.
there is a thromboembolism risk. Then, what do you see in the chest X-ray? Pen paper. Chest X-ray. Favorite question of the examiner. So, typically, when you look at the heart shadow, here you have a aortic knuckle.
Yeah.
And there is a depression because of the pulmonary artery. But the moment pulmonary hypertension develops,
Yeah.
this depressed area of the pulmonary artery will equal with the aortic knob.
Okay.
So overall, the heart will have a
Flattened.
straightened.
Straight.
Straightening of the left heart border is an indication of the pulmonary hypertension, which is seen in severe mitral stenosis. Why severe mitral stenosis lead to pulmonary hypertension?
Pressure is going to pulmonary
Left atrium is
Will
drained
go
by
back
pulmonary
to-
veins.
Will go back
Yeah,
to
will go back
pulmonary
to the
vein.
lungs.
So that is coming from the lungs.
Yeah.
Lungs are coming from the pulmonary artery.
Yeah.
That's the reason the net effect is pulmonary artery hypertension.
Yeah.
And that lead to development of the right heart failure.
Yeah.
Because right ventricle is pumping.
Yes.
That is the reason what is the famous adage. The right heart failure most commonly is due to a cause in the left heart.
Okay.
And what is that which is the cause?
MS.
MS or even aortic
Yes.
stenosis also. Aortic stenosis also will increase the pressure in the left ventricle, left
Yeah.
atrium, pulmonary vein, pulmonary artery,
Artery.
leading to ultimately pulmonary artery hypertension, leading to
Right side heart failure.
right heart failure is what we need to remember.
Yeah.
And also there is a rupture of the bronchial veins leading to hemartesis.
Because of the
Hemartesis.
increased pressure.
Increased pressure. So what is the best way to diagnose the mitral stenosis, doctor? If you do 2D echo, you can see the fish mouth
mouth
appearance
appearance.
because of the valvular commissural fusion
Okay.
is what we need to remember. So how do we treat? Always decrease the myocardial oxygen demand by giving beta blockers. And always right heart failure is treated with the diuretics. Left heart failure also అనుకోండి కాకుంటే ఇక్కడ pulmonary hypertension will be there, pulmonary congestion is there, so you need to give diuretics for the symptoms. So what is the definitive treatment? Tomorrow Viraj will go interventional radiology. Percutaneously will go in mitral valve commissures which are fused, you will do commissurotomy.
Okay.
Then when is the pulmonary percutaneous mitral commissurotomy contraindicated? If there is any clot sitting in the left atrium, or if there is any mitral regurgitation which is moderate, and if valves themselves are calcified, how can you repair them?
Yeah.
There you need to do valve replacement.
Procedure.
Mitral valve replacement
Yeah.
is what you need to basically do. That's all about MS. Compulsory MS के ऊपर क्वेश्चन नहीं आए तो I can bet on the honor.
Okay.
Graham steel is soft.
That's
Graham
pulmonary-
steel is
Pulmonary
soft. Is a mid-diastolic murmur of the pulmonary
PS.
regurgitation. PR.
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 Okay.
As much as Austin Flint is AR.
Yes.
Hmm. Early diastolic murmur is seen in
And
mid-diastolic rumble is seen in
MS.
MS.
MR is early diastolic.
MR is pansystolic
Pansystolic.
murmur.
Yeah.
అంతే కదా మీకు సిస్టోలి అయ్యేటప్పుడే కదా వెంట్రికల్ అది
Yeah,
రిగర్జిటేట్
go back.
అవుతుంది.
Yeah. Early diastolic is AR.
AR.
Yeah.
And how will the early diastolic murmur, where is it heard? It is heard in neo-aortic area. What is the aortic area?
Right side second.
Right second
Right.
intercostal space is aortic area. But left third parasternal area
Oh,
is the neo-aortic area.
okay.
And there, this aortic regurgitation sound is a low amplitude, high frequency sound.
Okay.
Low amplitude, high frequency sound. Aortic regurgitations, early diastolic murmur. So diastole means after lub or after dub?
After double.
After
S2,
dub.
Yeah.
So lub, dub,
Okay.
lub, dub, almost like a postcoital
Yeah.
sound. Huh? So lub, dub,
Okay.
and you should use diaphragm.
Hmm.
And you should ask the patient to lean forward when you auscultate it.
Okay.
Why? Because our breath sounds have the same kind of a frequency
Mhm.
as much as that of the
Yeah.
AR, early diastolic murmur. అది గుర్తుపెట్టుకోవాలండి. చాలు. Now, doctor, MR. The most common cause of the MR, once more, rheumatic heart disease. And acute murmur MR ఎప్పుడైతుంది? Whenever there is any myocardial infarction, then the papillary muscles can undergo rupture, and that can lead to the development of acute MR. Right? And America mein mitral valve prolapse is most common cause, but MVP also leads to MR. And what is the clue to say MR is severe? Every time left ventricle is trying to pump the blood into the aorta, it is getting regurgitated and going back.
To
The
the
left
atrium.
Left ventricle want to prepare for NEET PG. वो पढ़ने के लिए कोशिश कर रहे हैं आगे बढ़ने के लिए, मगर भूल जा रहे हैं और वो पीछे खो रहे. आफ्टर सम टाइम क्या हो जाता है लेफ्ट वेंट्रिकल को? कितना
Thickened.
पढ़े तो भी, कितना कोशिश करे तो भी पीछे ही जा रहे
Hmm.
blood. Then left ventricle at a point of time will fail,
Give up.
because that regurgitant blood and the regular venous return both will come and fall in the heart ventricle.
Dilated.
Over a period of time it get dilated.
Yeah.
And the moment the amount of cardiac output into the aorta decreased, the heart will be demanded for
More
increased
oxygen.
rate. So
Yeah.
that is the reason a hyper dynamic rocking left ventricle
Yeah.
with the S3 is the feature of the MR severity.
Okay.
Another favorite question, don't forget. You will never see the S3 or dilated heart if it's a pure mitral stenosis. Kaiku. Mitral stenosis का मतलब क्या है?
No blood
लेफ्ट
is
एट्रियम से ब्लड इतना ही आ रहे
थोड़ा
लेफ्ट वेंट्रिकल में.
Yeah.
लेफ्ट वेंट्रिकल को काम इच नहीं.
Yeah.
जिसको काम नहीं है वो कैसे फेल हो सकता?
Yeah.
राइट? करेक्ट?
Yes,
Yeah.
sir.
सो डोंट टेल मुझे बहुत टेंशन है इसलिए सीट नहीं आया. क्या टेंशन है? द मोस्ट हॉलीडे पीरियड इज
Preparation.
प्रिपरेशन टाइम. नो टेंशन. जाके शाम पे क्रिकेट खेल सकते, मैच देख सकते. यू राइट, this part of my life is sponsored by my mummy daddy because I'm preparing for NEET PG. Nobody will bother you. They won't even ask you to marry.
Yeah.
You can do anything. You can date, you can break, you can make anything. So MS is like the NEET PG preparing aspirant.
Hmm.
Whereas MR is like a postgraduate student.
Dilated.
घर में सुंदर बीबी वेट कर रहा है जैस्मिन फ्लावर्स लगा के. इधर HOD is angry on you with a constipated face that you did not finish the discharges. And the patient will say, morning से मैं वेट कर रहा हूँ, क्या है डॉक्टर साहब ये? right?
Yeah.
So life is miserable. You have to present journal presentation, you have to do case presentation, blah 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 blah. So finally you feel, किसके लिए मैंने MD किया? Suddenly your friend will call. Hey, 1 month back I got married and already she is pregnant. Of course, that's because they had been hanging around before marriage also. And you are in third year, final year MD, still you could not be able to impregnate. Huh? So that is the reason mitral regurgitation is like PG. इसमें S3 gallop होगा, LV failure होगा, LV dilatation होगा, मगर MS में,
No.
प्योर MS में नहीं होगा. अगर हुए तो उसका मतलब वो प्योर MS नहीं है, उसमें MR भी है, नहीं तो AR भी है, नहीं तो AS भी है. Unless AS or AR or MR is there, pure MS can never lead to left ventricle failure. ఎందుకంటే దానికి లోడే ఇస్తలేదు అది. Right? It's like a government job.
I will not work.
Huh?
I will not work.
I'll not work. Do whatever you want. So, how is acute MR presentation? There is a lot of blood regurgitating from left ventricle into left atrium, and left atrial pressure is increased, and that is a back pressure on the pulmonary veins.
Yes.
That leads to pulmonary edema. And forward flow is not happening. There is a shock.
Hmm.
And there is a dyspnea. If the blood is not coming, you can't run, fatigue.
Yeah.
Then the left atrium also will dilate,
Yeah.
and that lead to AF.
Finish.
Yeah.
And if you do, ready here?
Yeah.
So, అవునా?
Yeah.
Okay.
ఎందుకు సార్ ఇంకొక హాఫ్ అన్ అవర్ అయిపోతుంది?
Very good. 2 minutes, we'll take a voice break. So let us restart the journey.
Oh.
Now, this is a favorite question of the examiner. MR murmur intensity.
Yeah.
If you do hand grip
Yeah.
exercise, that lead to vasoconstriction, which will increase the systemic vascular resistance after load against the ventricle. So that ventricle regurgitation will increase once more. If you do hand grip exercise, that lead
increasing the
to
preload.
rise of catecholamines, which will lead to vasoconstriction and afterload on the heart, and regurgitation will increase. Second, if you are standing, there is a decreased venous return. Decreased venous return.
Yeah.
So obviously, if there is a decreased venous return, there is a decreased preload of the heart.
Yeah.
If the amount of the preload is decreased, then the amount of the blood coming from atrium into ventricle will decrease,
Yeah.
and that will decrease the
MR.
regurgitant also.
Yeah.
So what the best investigation do? 2D echo in MR. Huh? If the EF is less than 60%, that means left ventricle failed, means it is a severe MR. And what is the definitive treatment? Repair or replacement. And always, what is the medical therapy for all regurgitant lesions? If you do vasodilatation by giving ACE inhibitors, beta blockers,
Intensity.
or you give diuretic by decreasing preload, vasodilatation will decrease the regurgitation. అంతే కదా? Forward pressure will decrease, that will cause backward pressure regurgitation from ముందు నుంచి pressure push చేయదు కదా,
Yeah.
from aortic pressure will put push on ventricle will cause the regurgitation more.
Yeah.
High ventricular pressure.
Yeah.
So that's the reason we give ACE inhibitors, beta blockers, diuretics to treat the mitral regurgitation. Now a very important rule. All the regurgitant lesions improve in pregnancy. Why? In pregnancy, there is a high progesterone. Progesterone lead to smooth muscle relaxation of the blood vessels, leading to vasodilatation. That will decrease the peripheral resistance, and that will decrease the regurgitation. All stenotic lesions worsens with pregnancy. Typically, pregnancy is a state of high plasma volume.
Yeah.
That will increase the amount of the blood returning to the heart.
Yes.
If there is a stenotic lesion,
More the work.
you are trying to push more blood across a stenotic valve. That's the reason all stenotic lesions worsen with pregnancy, all regurgitant lesions improve with pregnancy is the rule.
Yeah.
Right? Now, one of the very important causes of MR is mitral valve prolapse. What is the hallmark of mitral valve prolapse? In mitral valve prolapse, when the ventricle is undergoing systole, normally the mitral valve is prevented from bulging back into the atrium because of the chordae tendineae which are holding it.
Yes.
Right? It's like the air balloon
Yeah.
in Belgium, Netherlands, where we fly on.
Yeah.
It is preventing that from bulging.
Yeah.
The moment there is a myxomatous degeneration of these chordae tendineae in conditions like Marfan syndrome,
Post-MR.
then that lead to tendency for
Bulging.
prolapse. So prolapse is an event that happens during ventricular systole or diastole?
Systole.
Systole. And whenever the prolapse is happening, the chordae tendineae, which are myxomatously degenerated, will undergo tightening, and that lead to that musical sound which is called systolic click. At the same time, it can even lead to regurgitation altogether. Obviously, when left ventricle is undergoing systole and wanting to push the blood into the aorta, this prolapse led to one small opening, no?
Yeah.
That lead to blood to go back from left ventricle into left atrium. So that's the reason there is a late systolic murmur and systolic click, which is the hallmark of MVP,
Mitral
is what you need to remember. If the person is standing, what will happen?
Decrease premium.
There's a decreased venous return.
Yeah.
And a decreased venous return will cause
Increase in the amount.
smaller size of ventricle,
Ventricles.
which lead to prolapse more.
Okay.
So MVP murmur will increase with standing.
Okay, sir.
If the person is doing Valsalva maneuver, which is opposite to inspiration, that lead to inspiration increases the venous return, expiration decreases the venous return, decreased venous return, smaller size of the ventricle, that lead to worsening of the MVP murmur. Similarly, if you are squatting, what is happening opposite to standing?
Increase in the
That will increase the venous return. Ventricle size bigger, MVP murmur smaller is what you need to remember. Marfan, Saheladon, Los,
congenital.
they're all MVP associations. And mitral valve prolapse people also can have atrial septal defect. Mitral valve prolapse patients can also have ASD associated. ఇది గుర్తుపెట్టుకోండి. The most common arrhythmia that happens in MVP is premature ventricular complexes, because ventricle got tired due to this regurgitation business, and that lead to premature ventricular complexes, ventricular tachycardia, atrial fibrillation and all. And infective endocarditis, high risk lesion, MVP. And that lead to development of infective endocarditis. And that in infective endocarditis, vegetations themselves will worsen the
Regurgitation.
prolapse,
Yeah.
right? And that can cause severe MR. So how do you treat? Lot of women around us will have MVP. That's the reason MVP is called overdiagnosed condition on 2D-co. ఎవరికైనా 2D-co పెడితే ఉండొచ్చు,
Okay, so that's
symptoms ఉండవు.
that count.
Similarly, some patients will come. Recently, I married doctor. After this, the palpitation started. All because of this stupid fellow who married me. So, stupidity is there in the mitral valve prolapse. Commonly presents with palpitations. ఇంతకుముందు asymptomatic ఉండే. Recently start అయినాయి. That is because that MVP started little regurgitation. కొంతమందిలో ఏం లేకుండా 2D-co చేస్తే స్క్రీనింగ్ కార్పొరేట్ యాన్యువల్ బాడీ చెకప్లో MVP వస్తుంది. అట్లా MVP, if there is symptoms like palpitations, anxiety also in women especially, beta blockers are given. Beta blockers. Why beta blockers? Beta blockers slow down the heart rate. Beta blockers lead to increased diastolic filling time because of the slowing of the heart rate.
Okay, sir.
And that increased diastolic filling time will increase the filling into the
Ventricle.
increase the size, decrease the prolapse. అందుకోసం HOCM అయినా MVP అయినా we give the beta blockers. Finish. That's all the story of MR and M. ఇది లేకుండా తప్పించుకోలేరు మీరు ఎగ్జామ్. If you are thinking of big scores, you have to go through అబ్బా మళ్ళీ వాడిని పిలవాల్సి వస్తుందేమో, దీని పవర్ అయిపోతుంది.
Yeah.
Your laptop, sir.
Always Dockwin is a wonderful student. At least he makes me feel that I am teaching. Now, aortic stenosis. Most common cause? Calcific degeneration as we become old. Lot of times, whenever you do 2D echo or X-ray, you will find that calcified valve above 70. Then, what is the most common cause? Less than 70 years. Normally, 3 cusps will be there for aortic valve, only bicuspid aortic valve. A lot of these people with bicuspid aortic valve, right? They do have aortic stenosis, but they are asymptomatic. But the moment they hit their 50th year, they get hypertension. So then what will happen? Already aortic stenosis is unable to pump the blood from left ventricle into aorta. On the top of it, their hypertension will cause
Most
worsening.
worsening of the condition.
ఇది ముందు తోయడానికి కష్టపడుతుంది. ఆల్రెడీ ఆడ హై ప్రెషర్ బిల్డ్ అవుతుంది hypertension తో.
Yeah.
Together when they happen, an asymptomatic bicuspid aortic valve will then become symptomatic. Right? And rheumatic AS. Rheumatic AS never occurs in isolation. It often happens along with the mitral valve. MS plus AS comes as an offer. Now, what is the classical clinical feature of aortic stenosis? Triad.
Unable to go into
Exertional angina, exertional syncope, exertional dyspnea. Endukandi? First of all, angina.
Yeah.
Once there is an aortic stenosis, the left ventricle blood is unable to enter into the root of aorta.
Yeah.
Root of aorta pressure is low, and that pressure will decide the perfusion into coronaries.
Yeah.
Okay, sir.
And the coronary perfusion get diminished.
Hence angina.
Coronary perfusion get diminished, and that lead to development of angina. Number 2, exertional syncope. So basically, the blood supply to the cerebral vessels come from the aorta, right?
Internal cavity.
So why it is exertional always? Even if aortic stenosis is there, the heart is able to somehow increase inotropic state and push the blood into the aorta. The moment he is watching the TV and there is a sixer by Rohit Sharma, he gets up in excitation.
Yeah.
Excitation require more cardiac output.
Yeah.
But here, what is the situation? Fixed cardiac output.
Yeah.
Right?
Yeah.
You want to go to Europe, but you are a government employee getting a fixed salary. Then what will happen? Exertional syncope. आपका ड्रीम ख्वाब ही रह गया.
Yeah.
So exertional syncope. So also exertional dyspnea. So whenever you are exerting, you are expected to push more cardiac output, but it's a fixed cardiac output. That's the reason the left ventricular pressure remain elevated, because unable to push. Left ventricular pressure elevated. That lead to pulmonary venous congestion worsen. So that lead to dyspnea. Tell me, what is the triad of clinical features in aortic stenosis?
Exertional angina.
Syncope and dyspnea. Typically all the three, what is the adjective? Exertional is what you need to remember. Then there is a murmur, which is a crescendo, decrescendo, systolic murmur. So what do you find?
Crescendo.
Zoom, it will rise, and zoom, it will fall. So harsh, crescendo, decrescendo, systolic murmur in aortic area. What is the aortic area? Right second intercostal space. And it radiates to carotid. And in this, S2 will be soft or absent in severe AS. In severe AS.
Because back pressure played first.
Severe AS typically it become soft.
Ante kada sir?
Or even absent A2.
Reason absent it. Okay. Yeah, because there is.
So quickly check.
It is not closing quickly, sir.
No, mild AS moderate, AS, how is S2? The second heart sound can be affected depending on severity. In mild to moderate cases, S2 may be normally split, but in severe cases, the aortic component may be delayed and merged, resulting in single S2. A to P2, both of them get merged.
Sir, I got it, sir. A2 is delayed kada, sir, because
Correct.
blood
Adi arthamaindi.
So adi
Is it soft or loud? Adi, that's what we want.
Soft S2 can be indicative of conditions like
Soft or loud? A soft S2 can be indicated of conditions like aortic stenosis, right? Or pulmonary stenosis, both of them.
loud S2.
Loud S2 can be associated with conditions like pulmonary hypertension or a prosthetic valve.
So only MS is loud till now, whatever we learned. Ante
MS low, S1 loud.
Huh.
Once calcified valves are there, it becomes softened.
Softened.
Whereas PS and AS are associated with the
Soft.
soft second heart sound. But in case of severe AS, A2 becomes so delayed, it will merge with P2 and it will become a single
Single sound.
heart sound. Right? Now, what is the nature of pulse in AS? Pulse is parvus et tardus. Because of that stenosis, the pulse will slowly raise and it is a low volume pulse.
Yes.
And how is the apex beat? It will be raising and it will be sustained. If you feel the apex beat, left ventricle is trying to push slowly blood, squeeze it into the aorta, no?
Right.
So because of that, what will happen? It will rise, but it will remain sustained, heaving apex. Then what is Gallagher phenomena? Once there is an aortic stenosis, there is a high frequency murmur. High frequency and low amplitude murmur.
Yeah.
High frequency and you have to hear with the diaphragm, which is not at apex. Right? So this is something that you need to know. What is the mechanism of Gallagher phenomena? Chattu bhai ko puchenge. Right? So it is a variation in the quality of the murmur of aortic stenosis. Specifically, the murmur has two components. A low frequency harsh murmur, best in the right upper second intercostal, which is characteristic of AS. Additionally, there is a high frequency musical murmur heard in the apex. Because when the AS is very severe, right?
Yeah.
AS is very severe. Left ventricle pressure increases, that it lead to a functional MR.
Okay. Due to increased pressure in the ventricle.
High frequency musical murmur heard in the apex.
Okay, sir. We'll just remember Gallagher.
But it is not due to actually murmur.
Yeah.
There is no MR developing. It mimics MR. Because MR murmur also is the pansystolic murmur radiating into axilla. Right? So, the turbulent flow of the aortic stenosis, in 130, the left ventricle blood is trying to move into the aorta and create a lot of vibrations.
Yeah.
And they become conducted back onto the heart valves. That is mitral valve.
Okay.
And that lead to the high frequency component of the turbulence traveling towards the apex from the left ventricle.
Yeah.
That lead to that high frequency turbulent musical MR kind of a systolic murmur, mimicking systolic murmur. Adi story. That's called Gallagher phenomenon. Gallagher phenomenon. Normally, it should go to galla. Aortic stenosis radiates into carotid.
Yeah.
Now, echo. When you call severe AS, the moment the valve area is less than 1 centimeter square,
Just like
even aduthandi common questions. And what is the pressure gradient? If the mean gradient between the aorta and ventricle is more than 40, That means which is more?
Ventricle has to be more good.
Ventricle will have more pressure compared to aorta, more than 40, or peak pressure gradient more than 64.
When it is completely contracted.
Yes, and LVH will show a strain pattern. What is the strain pattern? T waves get inverted, ST segment get depressed. That's called strain pattern.
Opposite of MI.
No, ST depression is because of the LV ischemia,
Okay. Sir.
whereas T wave inversion is a feature of called strain pattern. So, chest X-ray. Once aortic stenosis is there, right? Whatever the aorta after the stenosis is there, it will undergo post-stenotic aortic dilatation. Is the classical radiograph.
On chest.
Straightening of the left border of the heart is a feature of pulmonary hypertension in mitral stenosis, right? So what is the definitive treatment? You have to do surgical aortic valve replacement or TAVR, trans catheter aortic valve replacement. TAVR, very popular. Left and right we do TAVRs in TX hospital. Now, what is the indication for surgery? The moment the EF goes less than 50%, or if the patient of aortic stenosis became symptomatic, that is an indication to replace the aortic valve. Right? So, what drug is contraindicated in aortic stenosis? Always remember, vasodilators are indicated in
stenotic conditions.
Regurgitant.
Achha, you're supposed to reduce. Sorry,
Because
and always contraindicated in stenotic condition. ఎందుకు vasodilation అయిందనుకోండి, there's an increased preload to the left atrium, to left ventricle, and that will worsen the stenotic lesion, which is not able to pump it into the
ventricle.
అయితే ఇక్కడ నైట్రేట్స్ ఎందుకు అసలు ఎందుకు why to mention nitrate? Because what is the classical triad of clinical features of AS?
Syncope, angina,
Dyspnea.
and dyspnea.
And angina.
Yeah.
Anginaకి నార్మల్ గా నైట్రేట్స్ ఇస్తాం కదా, HOCM లో ఇవ్వద్దు, సివియర్ అయోటిక్ స్టెనోసిస్ వల్ల వస్తే ఇవ్వద్దు. Only if at all the angina is because of coronary atherosclerosis, nitrates are good. Okay, doc? Now comes the aortic regurgitation. ఉన్నదా పెట్రోల్ అయిపోయిందా?
It chases them.
Huh?
It chases them. Yeah.
ఎక్కడ ఉంది అది? Good. Kita there was
Meets the stall.
1 hour 16 minutes.
15, eh?
Yeah.
Okay. 31. ఎంత 12 pages కి అయిపోయిందా పెట్రోల్?
College.
Late. Sir.
కొంచెం కార్డియాలజీ కొంచెం గుంజుతుంది.
Yeah.
ఇంకెన్ని ఉన్నాయంటే 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 అయిపోయింది. ఇంకా 11 కండిషన్స్ ఉన్నాయి. పూర్తి చేస్తే కార్డియాలజీ అయిపోయింది. మనం ఆల్సో వి రీచ్ ఆల్మోస్ట్ 1/4 is over. Medicine is no joke. Medicine.
Yeah, 1/3.
Medicine is
30%.
1/4 is no joke. But anyway, it's fun as you go forward. The very little ఇవే పాయింట్లు గుర్తుపెట్టుకోవాలి. ఇది ఒక ప్రింట్అవుట్ తీసుకుని ఒక్కసారి చూడండి. వాళ్ళ పోనీ ప్రింట్అవుట్ వద్దనుకుంటే కనీసం
మీరు పెడతా నేను విరాజ్ యూ హ్యావ్ దిస్.
Yeah, I'll forward it now.
మళ్ళీ రిపీట్ అవుతుంది సార్ mitral valve prolapse.
Okay, let's do aortic regurgitation quickly. West में bicuspid aortic valve, aortic root disease. Root disease, what is the cause, doctor? Marfan syndrome can cause aortic root dilatation. Syphilis can cause a lutic degeneration of the
tertiary.
అదేం
Media,
చేస్తుందంటే
media.
it will cause endartritis. Who? Syphilis.
Syphilis.
So it will cause the wall of the aortic root to become necrosed. That lead to aortic root dilatation and the valve become stretched and that lead to regurgitation. Then acute aortic regurgitation, what are the causes? Infective endocarditis. Similarly, aortic dissection where the blood is seeping between the intima and the media.
Yeah.
So that can lead to development of acute AR. Chronic AR la symptoms ఏముంటాయి? Obviously regurgitation ఉంటాయి కాబట్టి there is a increased pressure on the
Lungs.
mitral, I mean atrium and pulmonary circulation. So dyspnea, orthopnea, P&D. And AR is the place where definitely ventricle fails. Even in AS it will fail. Only MS it doesn't fail. MR it will fail. అది గుర్తుపెట్టుకో. So chronic AR లో ఏముంటాయి? Dyspnea, orthopnea and P&D. Right? AR murmur is a early diastolic high pitched murmur in the neo-aortic area which is located in the third left parasternal space. Austin Flint అంటే ఏంటి? నేను చెప్పిన when there is a severe aortic regurgitation. When will aortic regurgitation occur? When the ventricle is in diastole or systole?
Diastole.
So during the diastole, when there is an aortic regurgitation, all that stream is falling back. Same time from the left atrium into the left ventricle, the forward stream is coming. Both will clash and that lead to a mid-diastolic rumble. And presence of Austin Flint is an indication of the severe aortic regurgitation. Remember. Then there is a bounding, collapsing pulse. You hold the pulse and rise, it will collapse because of regurgitation. And there is a wide pulse pressure, right? Then Quincke's sign, Corrigan's sign, Durozius sign, Hill's sign. You need to know all these important clinical signs. Quincke's sign. What is Quincke? Capillary pulsations happening in the nail bed. Why? Because there is an aortic regurgitation. Once there is an aortic regurgitation, there is a lot of diastolic runoff. అంటే ఏంటి? Ventricle pumped the blood into the aorta and aorta unable to deliver it forward because of the regurgitation. Right? That's called aortic runoff. దాంతో ఏమైపోతుంది? The heart is pumping out the blood, but that is coming back to the heart very fast. Circulatory time became shorter. And that lead to that hyperdynamic circulation. Appudu heart rate పెరిగిపోతుంది. Aortic regurgitation. Capillary pulsations in the nail bed is Quincke's sign. Visible carotid pulsations is called Corrigan's sign. And if you put the stethoscope on the femoral artery, it will show a diastolic murmur, which is called Durozius sign. And if you check the popliteal BP in the lower limb and the upper limb, the difference between them will be more than 20, which is called Hill's sign. Why?
Why is lower limb pressure more?
Popliteal BP more than brachial.
Why is the lower limb pressure more? Aorta is unable to push the blood to the okay.
చెట్టు పైసి పూచు. Why Hill sign? So Hill sign of AR. In AR, the aortic valve leaks. It causes wide pulse pressure, increased systolic and decreased diastolic pressure. That exaggerated systolic pressure is transmitted more prominently to lower limbs. That will amplify the pressure wave in peripheral arteries.
So popliteal pressure is more than the brachial.
Right. But still, Based upon the pressure difference between lower limb and upper limb, it is called mild if it is 20 to 40, 40 to 60 is moderate, and more than 60 is called severe aortic regurgitation. But now the question still is unanswered.
That is nice, sir. Koncham paikalan, sir. There is
Why more in lower limb than upper limb? Explain like class 5 student. Yeah, that's how
Maybe gravity.
you will get the answers.
So,
Your heart is like pump.
Yeah.
Your blood vessels are like pipes. Aorta is the main big pipe. The valve is a door. Okay, we all know that. What happens? The door valve is
why
broken
is
and
the
leaks.
pressure-
Ah.
Why is the pressure?
Why is pressure higher? Think of pipes going to your hands and pipe going to your leg. The pipes of the legs are longer, wider, like a big highway. When the heart pumps harder, the pressure wave travels further and builds up more energy as it moves along. Like water speeding up in the downhill pipe. The pressure gets bigger by the time it reaches the
low legs?
legs. If you shake a hose pipe with water inside, near your hand the shake is small, and the far area the water splashes out harder. Understood? That's called kill sign. We stopped asking questions.
Yeah.
Most of it you're explaining, Kapil, sir.
Today you don't need a teacher. You need ChatGPT. Any doubt you get, you ask. You ask how to remember. All murmurs. Give me a funny trick. It will do.
Teach you. Yeah.
Pujenge?
No. Sir, we can do it.
I'll show you. I'm going to conduct next time onwards only workshop on how to use ChatGPT for coaching, for preparation.
Yeah.
Give me funny trick to remember murmurs. Mr. Ash, is mitral regurgitation aortic stenosis is systolic? Miss ARD. Miss ARD not understandable. No?
Yeah.
Super fast cheat lane. Extra funny trick. Mitral regurgitation is at apex. Oh man. Ash shouts in the corner. Apex. Okay. More easier to remember with mechanism.
More easier to remember, like you said, sir, with concept.
Mnemonics are bakwas actually.
Not everything, yeah. Not
Some things like P450 inhibitors, inducers.
Yeah, అంటే లాజిక్ సబ్జెక్ట్ లో లాజిక్ ఉంటే నిమోనిక్ అవసరం
అవసరం లేదు.
లాజిక్ లేకుంటే నిమోనిక్ అవసరం
Logical things never be mnemonized.
yeah
Only hard to remember. वो भी 2-3 बार देखे तो लिस्ट को याद रहता. So now echo finding is what? If you do 2D echo, you can see that regurgitant jet,
Yeah.
dilated LV. And what is the type of hypertrophy that you see in AS, aortic stenosis? Concentric hypertrophy. This is called eccentric hypertrophy.
What's the difference?
ChatGPT. Concentric అంటే
Come.
రౌండ్,
Uh,
ఇక్కడ ఏదో ఎక్సెంట్రిక్ అంటే నాట్ ఫుల్ రౌండ్, ఫుల్ సర్కంఫరెన్షియల్ కాదు.
it's concentrated on one part.
Looks like. Right. Now, acute AR low. What is the most important 2D echo finding you will look at? LVE DP, left ventricular end diastolic pressure. So normally at the end of the diastole, the left ventricle is supposed to have some pressure. But AR में क्या हो गया?
Increase.
Regurgitant jet also added. That's the reason LVE DP will increase, is what you need to remember.
Basically, it is supposed, normally it's supposed to reduce, But
No,
because
no.
of the
It is
regurgitation,
supposed to be what it is.
Yeah.
It's some value
Yeah.
that become increased because of the regurgitation.
Okay.
Then surgical indication. If the EF is less than 50%
Hmm.
and left ventricular end systolic pressure is more than 50,
Okay.
end systolic diameter.
Okay.
So at the end of the systole, what do you expect the LV diastole to become? Decrease.
Yeah.
But because of the regurgitation in the earlier diastole, the amount of the blood remaining in the left ventricle
Yeah.
Yeah.
is increased.
Increased.
So LVESD will increase more than 50 mm is a surgical indication to remove that regurgitant valve. So definitive treatment is surgical. You need to do TAVR. Huh? Then medical treatment is always vasodilators are indicated in regurgitation, strictly contraindicated in
Stenosis and HOC.
correct. And what is contraindicated in AR?
Beta block.
Beta blocker. Why?
Because it
Because beta blocker will slow the heart and increase the diastolic filling time and increase the filling of the heart. Already regurgitated blood is full. On the top of it, you are filling.
more
No. Huh?
Yes.
That's what. Right? Then comes mitral valve prolapse. We already finished.
Yeah.
Right? Then comes heart block. Simple. First degree only PR prolonged, PR more than 200 milliseconds. Mobitz type 1. There's a progressive PR increase and drop.
Venke back.
Then that's called Wenke-Back phenomena. Mobitz type 2.
Yeah.
There is a constant PR. Gopal and Gopika are going to everyday reading room. They are reading same line in Harrison. Suddenly Gopika married and went to USMLE. Gopal heartbreak. So that can lead to, that is an indication for ICD.
ICT. Second. Move it.
Then third degree block, there's an AV dissociation, atria at its own rate, ventricle at its own rate because there is no conduction of the atrial impulses into the ventricle. That's the reason atrial rate, ventricular rate are different. The most common block that you see in MI is second degree Mobitz type 1 block, especially in inferior wall MI. Because inferior wall
Septum.
is due to RCA, right coronary artery. And lot of times posterior descending artery originates from right coronary artery. Posterior descending artery supplies the AV node in right dominant circulation. So in all such people, there is
Second degree Mobitz type.
second degree Mobitz type 1. And what is Mobitz type 2? Where is it seen? Anterior wall MI. Right? And it has a worse prognosis because when will the cardiac arrest occur? We don't know. Heart block, complete block occur. Right? Then third degree is seen in inferior wall MI, but that is reversible. Anterior wall MI में जो भी third degree complete heart block है, that is reversible. And because में inferior wall MI వచ్చిన వాళ్ళకి, before you pass a temporary pacemaker, you will give one shot of atropine. Atropine increase the heart rate. It removes the block.
Okay.
Acetylcholine vagus. Acetylcholine slows the heart. Atropine vagolytic will speed the heart. So that is the reason we give atropine. చాలాసార్లు హార్ట్ రేట్ మళ్ళీ నార్మలైజ్ అయిపోతుంది ఏది ఇన్ఫీరియర్ వాల్ ఎంఐలో కాకుంటే దెన్ వి నీడ్ టు పుట్ ఏ టెంపరరీ పేస్ మేకర్. So what is the Stokes-Adams attack? So typically when the heart block is there, transiently the heart will be going into asystole, it can't pump and that can lead to, but what I had is BPPV, not Stokes-Adams. Right, we don't know. Right. Next comes escape rhythm. Whenever complete heart block is there, ventricle will get its own pacing. Right. So if that escape is arising from AV node itself, lekunte under the AV node, infranodal or nodal. Once the node got blocked, AV node got blocked, the next pacemaker can take up in node itself, which got blocked. And it will supply the ventricle forward. Normally SA node to
AV
atria to AV node to ventricles, no? So the moment complete heart block is there, there are two possibilities. Ventricle itself can develop pacemaker, or that AV node which got blocked can become the pacemaker and help
the ventricle.
ventricle. So how do you recognize if it is a escape rhythm coming junctionally? It will have a narrow QRS and a heart rate of 40 to 60. If that is coming from the ventricle itself, then it will have a wide QRS and 20 to 40 heart
Rate is
rate.
more.
So if it is the only PR prolongation, we'll see in lot of elderly people, first degree heart block. Nothing need to be done. Mobitz type 1, give atropine if patient is symptomatic. Mobitz type 2, put a pacemaker. Third degree, once more, put a temporary, then a permanent pacemaker. Now, what is the contraindication to give atropine? Never give atropine.
If
Right?
the ventricle is itself dead.
If at all the block is located not in the AV node but below the AV node,
Okay. sir.
infranodal block. అంటే ఏవి నోడ్ నుంచి అది వెంట్రికల్ లోకి పోతున్నప్పుడు వెంట్రికల్ లెవెల్లో కనుక బ్లాక్ ఉందనుకో, then don't give. That means if the QRS is wide, don't give atropine. Then what is drug induced block? Those whom are receiving digoxin. ఎందుకు digoxin is vagomimetic. Yesterday I told no.
Yes.
It will slow down the heart rate in atrial fibrillation. So the vagomimetic properties of the digoxin can lead to heart block. Beta blockers, calcium channel blockers, which we use for treating hypertension, they also can lead to a drug-induced block. That is a very common cause of the first degree heart block, which we often see in the case of the elderly people. First degree means only prolongation of the PR interval. Now, if the mother is having SLE, anti-Ro antibodies are produced, which can lead to congenital heart block. Right? Now, wide QRS with AV block, infranodal below his bundle. Narrow QRS in AV block is
Nodal block
nodal block. Huh?
above the bundle.
Then permanent pacemaker indication of its type 2 and third degree. Khatam. Clear?
Yeah.
Compulsory వస్తుందండి.
Okay. sir.
అంటే 30 క్వశ్చన్లు 10 క్వశ్చన్లు కార్డియాలజీని.
Oh, really? sir? Okay. That's good.
Why students are scared about medicine? Medicine require your physiology, pharmacology, microbiology. అవి ఏం చదవకుండానే కదా మనం పాస్ అయ్యేది.
It's volatiles.
Huh? గట్టిగా ప్రొఫెసర్ అంటే
I think
हम फीस पे करे तो आपका तनख्वाह है. क्या बोल रहे आप? हाँ? Really also, MBBS is all about that short run. Long jumper, short run. Every time we are trying to pass exams and come out. Kada? So we accumulate a lot of things that we don't see. Who will get the experience to see ophthalmology in 1 month posting? Everything is imagination. Where is retina? Where is vitreous? What is Hill's disease? And all that.
yeah.
So, doctor, ఇంకొక 4-5 ఉన్నాయి.
Yeah.
దాంతో కథానిక పూర్తి చేద్దాం. టైం ఎంత అయింది?
6:30.
6:30.
అండ్ हमारा कितना
1 hour,
मीटर चला?
50 minutes.
1 hour?
I'm guessing.
1 hour 50, yeah?
We must.
Yeah, so you started at 4:50.
No, 1 minute.
No, it'll be less 1 hour 45.
Ammo.
Toddler toddy.
Hope it's not gone, no?
Toddler toddy addiction.
Toddler toddy addiction. Hyderabad?
Yeah, it's there.
What
1 hour 37. Yeah.
1 hour?
37 minutes.
Oh, not bad, eh?
Yeah.
ఇంకొంచెం ఉంది. ఎస్విటీస్ ఒకటి,
BT.
ఏఎఫ్ ఈజీ,
Sir, AF already. Sorry.
ఫ్లట్టర్ 3, సస్టైన్డ్ వెంట్రికులర్ టెకికార్డియా,
SVT.
సుప్రా వెంట్రికులర్,
Yeah,
Supra.
super.
వెంట్రికులర్ VT,
Pulse.
pulmonary hypertension. Either మిక్సోమా చిన్నదే ఇది. కన్స్ట్రిక్టివ్ పెరికార్డైటిస్ 6, టాంపనిడా నెక్స్ట్ అంతే. ఎన్ని 6, 7
చేసేస్తాం.
చలో. ఆ తర్వాత
You can put an end to cardio.
రామచంద్రాయ ఎక్కడున్నాం మనము?
ఇది సార్ QRS అయిపోయింది.
అయిపోయిందా?
అయిపోయింది. MVP.
ఓకే, హార్ట్ బ్లాక్
Heart
అయిపోయింది.
block అయిపోయింది.
బారే బా. Then let us talk about SVT. Bhaiya, any narrow QRS tachycardia, unless proven otherwise, is SVT. Right? And the most common cause of the SVT, it can originate in SA node, it can originate in atria, it can originate in the AV node, right?
Yeah.
It's called atrioventricular nodal reentry pathway. एक सर्क्यूट घूमता उसमें, किसमें? AV node में. That's called AV nodal reentrant tachycardia. That is the most common cause of SVT. The rate in the SVT will be 150 to 250 and it is regular. And the hallmark is a narrow QRS. And you don't find the P waves because P waves become hidden or inverted. Enduko? AV node is throwing impulses. He became boss. Then he will tell the atria, hey, you excite by my command. So normally it should come from there to here. A usko deta hai. It's like Bangladesh emergency. Huh?
Yeah.
President is thrown off. So the retrograde conducting depolarization to atria will lead to inverted P wave, or because of the ventricular rate, which is very fast, P get buried. Right?
Yeah.
So AVNRT, AV nodal reentrant tachycardia, is because of a slow, fast pathway which lead to reentry in the AV node. Then what is WPW syndrome? Directly atria and ventricles are connected by the aberrant pathway and they bypass the AV node. That is called WPW syndrome. Because of that, what will happen? AV node is the one which will cause the delay for the P wave becoming QRS.
Yes.
From atria into ventricle. So PR interval, which is between P wave QRS, is created because of AV node. If that is bypassed, the PR becomes short. The PR become short.
Yeah.
And when the ventricle is excited,
Yeah.
when the ventricle is excited, one regular wave from SA node to AV node to ventricle is causing the QRS. And this reentrant pathway is also causing ఇనీషియల్ స్లర్రింగ్. ఇట్లా పైకి వెళ్తుంది కదా ఆర్ వేవ్, అక్కడ స్లర్రింగ్ వస్తుంది,
Okay, sir.
కొంచెం స్లర్రింగ్ వస్తుంది.
Okay.
దట్స్ కాల్డ్ డెల్టా వేవ్.
Okay.
ద ఇనీషియల్ పార్ట్ ఆఫ్ దట్ upstroke of the R wave, small slurring is delta wave. And the QRS become widened. So that is WPW syndrome. Okay. Now,
This is the only SVT where the QRS is widened.
correct.
All
When the aberrant
SVTs
pathway is
are,
there.
yeah, all the SVTs are narrow, kada sir.
Very good.
WPW is
Good
wide.
observation. What do you call MAT? Multifocal atrial tachycardia. So in the atria, multiple areas became active. And some P waves are upright, some P waves are inverted. So more than 3 P wave morphologies with irregular heart rate are there, means the tachycardia is originating in the atria. So whom do you see multifocal atrial tachycardia? COPD, hypoxia, right? Give me 2-minute break, huh?
Yes.
2-minute voice break, please. So, lot of times patients with COPD, hypoxia, they develop multifocal atrial tachycardia. How will you recognize,
Different P waves.
One ECG strip will show 140 heart rate. Another ECG strip will show మళ్ళా ఒక 4-5 గంటల తర్వాత చేస్తే 50-60.
అంత difference.
That's how, and in that you will have absent P waves. Another strip you will have P waves inverted. So more than 3 P wave morphologies with irregular heart rate more than 100 is diagnostic. Then carotid massage. If you do carotid massage, vagus will get stimulated if it is AV nodal reentrant tachycardia or AV. There is one AV reentry, AV nodal reentry. AV reentry ante your Wolf Parkinson White syndrome lo directly from atria into
Ventricle.
but that is not AVRT.
Yeah.
AVRT ante
No, sir.
typically from
SVT. Basically, SVT ki treatment is carotid massage.
correct.
If it is Wolf
If it is
Parkinson,
ventricular, it has no effect.
yeah.
And WPW also no effect
Effect.
because that is bypassing the AV node.
Yes.
What is the point in creating refractoriness in AV node by stimulating the vagus? That's the point. So we use adenosine is the drug of choice to terminate the SVT. Beta blockers, they can be used to control the rate in SVT.
So the SVT lo, also do you have something like stable or unstable?
Obviously, if VT low, any VT or SVT, you look for hemodynamic stability, right? So whenever a patient with SVT comes, heart rate is running at around 180 or so, and your cardiology PG is that day first night, he has no time to come to help you.
Yeah.
So basically, sir,
He will give a call and say, do carotid massage. I am also doing the same here. But don't do both carotid same time and send the patient to complete the God job. You're asking?
why?
Huh?
No, sir. That's what, sir. Stable untene we can do the carotid massage
No,
along
no.
with giving
Heart
adenosine.
rate ఎక్కువ ఉంటే carotid massage try చేయాలి ముందు. Or you can take his head and put in water. That is another way.
లేదు సార్ ఇప్పుడు హీమోడైనమికలీ అన్స్టేబుల్ స్టేట్ లో వచ్చి ఎస్విటి తో వస్తే వీ కెనాట్ డూ
ఉంటారు
కెరోటిడ్
ఆటోమేటికల్లీ అన్స్టేబుల్ స్టేట్ లోనే ఉంటారు.
అప్పుడు మనం
No, no, not for that. You will be giving adenosine is the treatment.
దట్ ఈస్ దేర్
Defib,
Adenosine is the treatment. There is no role for
defib just
defibrillation.
VT and VF.
అంటే దీంట్లో కూడా చేయొచ్చు. అన్స్టేబుల్ ఉంటే కూడా
ఎగ్జాక్ట్లీ
హైమోడైనమికలీ అన్స్టేబుల్ ఉంటే వీ కెన్ డూ.
there is no time for carotid massage and adenosine too అంటే it will take little more time defib is more faster కాబట్టి unstable లో first protect చేయాలి కాబట్టి అది చేస్తాం.
Another important rule. Generally we give digoxin for any tachyarrhythmia.
Yeah.
But never in WPW.
It will not work.
Why? Why? Digoxin will make the AV node refractory.
Already it is
No, no. The conduction in WPEW is happening outside the AV node.
yes sir
Dantoti further AV node getting disappointed will encourage
this real
this atria to ventricle conduction and worsen the WPW. So what is the drug of choice for tachycardia in WPW?
You have to-
Propafenone. Propafenone.
propofol.
Propafenone. It will selectively go and make these reentrant pathways get refractory instead of touching AV node.
Yeah.
So don't give digoxin is contraindicated for arrhythmias in WPW. Favorite question of the
So,
examiner.
also you can ablate those pathways kada.
Yes, that is called definitive therapy and radio frequency ablation. Right? So stable SVT, do vagal maneuver, give adenosine.
Okay.
Unstable, you give immediate synchronized cardioversion. And definitive treatment, radio frequency ablation.
Yeah.
In the MAT is often due to hypoxia. So give high oxygen insufflation, positive end expiratory pressure, PEEP,
Yeah.
etc. in case of
Mat.
MAT. Then comes atrial fibrillation. So how will you recognize it? Absence of the P wave, irregular rhythm.
Yeah.
Which lead will you look for the P wave's absence?
Second.
Second. Lead 2 is called rhythm lead. And what is the atrial rate? 350 to 600 beats per minute is the atrial rate. Ventricular rate is 100 to 180. మరి ఎందుకండి 100 to 180 ఉంటుంది వెంట్రికులర్ రేటు అంటే the moment very high atrial fibrillation is there,
Yeah.
it automatically will induce a AV block
Okay.
so that the ventricle rate will become
Step.
diminished because all that atrial fibrillation cannot go into the ventricle. The most common cause of the atrial fibrillation worldwide is Lachakka, Buchava having rheumatic heart disease with mitral stenosis leading to left atrial enlargement leading to
Fibrillation.
fibrillation. The most common cause in the case of the elderly is hypertension. Coronary artery disease will lead to the development of atrial fibrillation. Lot of elderly people we find above 80 you lived and atrial fibrillation compulsory.
దాంతోనే
They will all be taking emidaron. Emidaron lead to skin pigmentation.
Blue.
5 side effects.
blue man.
Blue, gray pigmentation. తర్వాత
Pulmonary
corneal
fibrosis.
opacities. It's called verticillate keratopathy.
Okay, sir. BOR.
It also lead to both hypo and hyperthyroidism. Both can happen with emidaron. It can lead to pulmonary fibrosis. Before starting the
Amiodarone.
emidaron, you need to get a HRCT chest and document that he doesn't have
Pulmonary fibrosis.
fibrosis. లేకుంటే మళ్ళీ వచ్చి he will sue you
Okay.
because of this. Because old people very intelligent. అమ్మో. Huh? His entire retirement will be paid by you. So the most feared complication is atrial fibrillation can lead to thromboembolism. Then there is a score called Chad-Vasc score. CHA to DS2 Vasc score. What is the full form of it? You should know. किससे पूछेंगे? चट्टू भाई को पूछो. Good. Everybody gone. Only we will become topper.
Then congestive heart failure, age, T2, then rest I forgot.
Congestive heart failure,
Hypertension.
1 point. Hypertension, 1 point. Age more than 75, 2 points. Diabetes, 1 point. Stroke, 2 points. CHAD, S2, V. Vascular disease like peripheral artery disease, aortic plaque, MI, 1 point. Age 65 to 74, 1 point. And the sex category, female, 1 point. So that's how it is. So total score of ఎంత ఉంటుంది?
9.
9, eh?
9. Maximum score.
Maximum score 9. Right? Stroke risk ఎంత 9 ఉంటే 100%. ఎంత 15 to 20%. Risk is there.
Score interprets the chance of getting stroke in AF.
Stroke, thromboembolic stroke,
Yeah.
hemorrhagic stroke వచ్చేస్తుంది. So more than 3 chat score ఉంటే you need to start immediately rivaroxaban, oral anticoagulant, strongly recommended. Day in and day out ఇదే ఉంటుంది ట్రీట్మెంట్. Direct acting oral anticoagulant, rivaroxaban, apixaban, etc. So acute AF లో ఏమవుతుంది? If it is less than 48 hours, you can do cardioversion if he is hemodynamically unstable. More than 48 hours అంటే ఆల్రెడీ క్లాట్ ఉంటుంది. మీరు cardioversion చేసి రివర్ట్ చేస్తే so anticoagulate him for 3 weeks before cardioversion. So what are the rate controlling drugs? Beta blockers, Dilrias and Digox.
Calcium.
What is the rhythm controlling? Emidaron, flecainide, sotalol will bring back the sinus rhythm. So what is preferred? Only do rate control and anticoagulation in congestive heart failure patients, not the rhythm control. So what do you mean by lone AF? no structural heart disease, less than 60 years, a good number of people can have AF, which is called the lone AF.
With no issues.
Then what is valvular AF?
MS.
MS or prosthetic valve with AF. And warfarin is the treatment especially with prosthetic valve or any valvular heart disease if they have not rivaroxaban, ఇవి కాదు.
Warfarin.
Non-valvular AF లో anticoagulant of choice is direct acting oral anticoagulant agent. After cardiac surgery, AF risk is there. And whenever there is any permanent AF, rate control only. Rhythm को sinus मत लाना. खाली rate को control करके AF में ही रखो. And definitive therapy is pulmonary vein isolate ablation. ఎందుకంటే that is the place where
Clot.
pulmonary vein isolation, that is the place where you get that focus of atrial fibrillation most commonly.
Okay, sir.
Then what is flutter? Flutter means heart rate is 250 to 350, whereas the ventricular rate become half of that atrial rate because the AV nodal block induced by it. So sawtooth like pattern you see in 2-3 AVF, this will come in exam. Sawtooth flutter waves, where do you see inferior leads? 2-3 AVF. And what is the type of the rhythm? Regularly, irregular or regular. And ischemic heart disease, structural heart disease can cause flutter. COPD, thyrotoxicosis, post-cardiac surgery and all. And atrial fibrillation is also called holiday heart syndrome. Mr. Daru wala, रोज दारू पिए तो alcohol excess can lead to
Exaggeration.
AF.
Okay.
That's the reason AF को holiday heart syndrome बोलते. Right? So in this, most of the points are covered, same like AF. Hmm?
But you're also giving rhythm control here, sir. Akkada rate control only.
Hmm.
AF lo rhythm control కూడా ఇస్తారు.
కూడా ఇస్తారు. Then VT. When do you define VT?
QRS.
When do you call sustained VT? Whenever ventricular tachycardia is there for more than 30 seconds, you call
Sustained.
sustained VT. Non-sustained అంటే less than 30 seconds. Rate ఎంత ఉంటుంది? 120 to 250 ఉంటుంది. QRS wide ఉంటుంది. Wide అని ఎప్పుడు define చేస్తారు? If the QRS is more than 120 milliseconds, you call it as wide. And the most common cause of the VT any day is post-MI. Because that MI lead to ischemic necrosis leading to scar, and that scar tissue in the ventricle lead to a reentrant pathway that lead to
VT.
sustained VT. And most commonly, coronary artery disease with infarct lead to structural disease.
So basically,
Polymorphic VT అంటే ఏంటి? QRS narrow, wide, tall, big, that is seen in
torsidis.
torsidis due to prolonged QT. Prolonged QT and more than QTC of
More than one,
240.
sir.
QTC more than how much is called torsidis. చెప్పకుంటే మై घर जाऊंगा अभी सीधा.
Don't remember.
More than 450 ఉంటే prolonged QT.
Okay.
420 corrected QT ఎట్లా క్యాలిక్యులేట్ చేస్తారు ఫార్ములా?
QT by RR square root.
Square root. Very good. Much for 450. Okay. Now, how do you know VT versus SVT with aberrant conduction pathway?
Both have wide QRS.
Both have got a wide QRS.
Yeah.
That's the reason. Normally SVT narrow ఉంటుంది, but SVT with aberrant conduction pathway will be also wide. How do you differentiate? And if it is VT, there's an AV dissociation. Fusion beads. గుర్తుందా ECG లో చూపించలే?
Yeah.
QRS complexes of abnormal shape. ఎందుకంటే if there is an aberrant pathway, ventricle is receiving the
Signals from the atria itself, but through the aberrant pathways.
through the aberrant pathway, sometimes receiving from
AV also.
అంటే ఎప్పుడైతే మన VT ఉంటుందో రెండు రకాల వేవ్స్ వస్తాయి. దాని ఓన్ tachycardia is giving QRS, and coming from the SA node also will sometimes merge. One gift from
VT.
wife, one gift from girlfriend, ఆ type లో.
Okay, sir. Okay.
तो fusion beats or capture beats will come.
In BT.
First जाते बीच में. Hemodynamically unstable unte BT, you have to treat by shock.
Cardio.
Hypotension ఇవన్నీ ఉంటే you call unstable. Unstable ki treatment is
Shock.
cardioversion and delivering 200 joules. Then acute stable unte IV emidaron or lidocaine.
Rhythm control.
A shock, B shock, 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 shock. A is emidaron, B is beryllium, C is lidocaine. You will also give lidocaine drip పెడతాం VT. మీరు రేపు ఇంటర్న్షిప్ లో జాయిన్ అయినప్పుడు చూపిస్తాను. I'm going to be professor of medicine, HOD in general medicine in Apollo.
Right. Yeah.
So I'll show you all this hands-on.
Yeah.
So acute stable treatment ఏంటి IV emidaron and or lidocaine. Torsitis ఉంటే ఏంటి ట్రీట్మెంట్ మర్చిపోవద్దు IV magnesium and pacing if needed. Then chronic prevention ఎట్లా BT లో ICD,
Defibrillator.
automated intracardiac defibrillator. So what is the role of emidaron? It will suppress the VT, improve the survival if you put it in the patients after MI. Right?
Yes.
And sotalol, it will also used as a maintenance therapy for VT. Sotalol is a potassium channel opener,
Class 3 antiarrhythmic.
antiarrhythmic. Then scar mediated VT ante after MI you will get that. Right? Must intagante ekku jaite waste. Then what else?
Ventricular tachyarrhythmias.
Ventricular fibrillation కొంచెం చదవాలి. అందులో most of the things ఇవే ఉంటాయి. Then comes pulmonary hypertension. ఇంకొక రెండు టాపిక్లు మై విద్యార్థి ఉంది. నేను పోయినాక ఇప్పుడు మళ్ళీ ఫిజిక్స్ చదివేది ఉంది.
Oh.
వెక్టర్స్, ఎడిషన్స్, projectile motion. Now, how do you define pulmonary hypertension? Systemic hypertension ante more than 140, below 60, more than 150, above 60. Regular BP, systemic hypertension.
Yes.
Pulmonary arteries low hypertension ante if the mean pulmonary artery pressure more than 25 at rest. Normal PAP is less than 20. How do you know the PAP? Pulmonary hypertension. Ideal gold standard ante pass a catheter, right atrium to right ventricle into pulmonary artery and it will measure. Then the pulmonary hypertension patients are divided into group 1, 2, 3, 4, 5 based on etiology. 1 is idiopathic heritable drugs. Group 2 is due to left heart disease can cause
Pulmonary.
back pressure and
Yeah.
group 2.
Yes.
Lung disease, the moment there is a COPD,
Yeah.
there is a alveolar hypoxia.
Okay.
Systemic vessels will vasodilate if there is a hypoxia. Pulmonary vessels will vasoconstrict if there is hypoxia. Difference between the two. That's the reason the one who smoked their life and the bad lungs are there. There is a hypoxia related,
Vasoconstriction.
alveolar hypoxia related pulmonary vasoconstriction leading to pulmonary hypertension. Those who have a chronic thromboembolism can develop
Group 4.
pulmonary embolism associated with hypertension, group 4. And multifactorial is group 5. The most common cause of pulmonary hypertension is left heart disease. And if you take histology, అది మళ్ళీ చూడండి బొమ్మ, plexiform hypertrophy of the pulmonary vascular media is a histological hallmark. So when pulmonary hypertension develops, they develop exertional dyspnea. The second heart sound become loud. ఇట్లా పెడితే left second intercostal space in the అదేం area, pulmonic area.
Pulmonary cases.
Tupuk, 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 top, it will be hitting you. If you do 2D echo, right ventricle is hypertrophied.
Yeah.
Because of the pulmonary hypertension, there is an increased pressure in the right ventricle, which will cause the tricuspid regurgitation to occur.
Okay.
So the TR will be there, functional TR, because of pulmonary hypertension. So TR, jet velocity more than 2.8 is a indication. Similarly, the central pulmonary artery get enlarged, pulmonary vasculature become prominent, and there can be straightening of the left heart border because of the pulmonary hypertension. Especially if the right ventricle hypertrophy అయిందనుకోండి, pulmonary hypertension toti expand అయినాయనుకోండి vessels, the whole thing will lead to straightening of the left heart border. So how do you treat? You can try the calcium channel blockers, and there can even be right atrial enlargement because of pulmonary hypertension, obviously. And between right atrium, right ventricle versus left atrium, left ventricle, which is more anterior?
Left is more anterior.
Right atrium, right ventricle are anterior. Immediately underneath your sternum, you have the right ventricle. Left atrium, left ventricle are posterior. They are closer to the esophagus.
Okay, so
That's the reason whenever mitral stenosis lead to left atrial enlargement,
dysphagia
it will
is
compress on the
Dysphagia loose.
esophagus. But అన్ని తెలుసు, అన్ని తెలిసినా అల్లుడి నోట్లో శని ఉందట, అట్లున్నది మన పని. Then immediately under the sternum, you have the right ventricle, most anterior chamber. అందుకోసమే whenever steering wheel injuries occur, it is the right ventricle that get injured is what you need to remember. Now, doctor, how do you treat pulmonary arterial hypertension? Endothelin receptor antagonist. Bosentan is the drug of choice. Surely ipoprostenol for severe pulmonary artery. Also, vaartam patient like we give ipoprostenol, we give bosentan, all these drugs, day in and day out medications. So, ivanni entante now it is all vinta. హాస్పిటల్ పోతే బెడ్కి ఒకళ్ళు, వార్డుకి ఒకళ్ళు ఉంటేనే ఉంటారు పల్మనరీ హైపర్, బికాస్ యువర్ సిఓపిడి కామన్ ఇన్ ఇండియా, పల్మనరీ హైపర్టెన్షన్, యువర్ డివిటి పల్మనరీ ఎంబాలిజం కామన్ ఇన్ ఇండియా, పల్మనరీ హైపర్టెన్షన్, సిస్టమిక్ స్క్లెరోసిస్ లైక్ వాస్కులర్ కనెక్టివ్ టిష్యూ డిజార్డర్స్ లో పల్మనరీ హైపర్టెన్షన్, లెఫ్ట్ అండ్ రైట్ ఉంటారు. ఫర్ నౌ వీ హ్యావ్ టు ఇమాజిన్ దే హ్యావ్ నో అదర్ వే. అండ్ వాట్ ఇస్ ద డెఫినిటివ్ ట్రీట్మెంట్? యూ హ్యావ్ టు గివ్ లంగ్ ట్రాన్స్ప్లాంటేషన్ ఆర్ హార్ట్ అండ్ లంగ్ రెండు ట్రాన్స్ప్లాంట్. మొత్తం పీకేసినాక ఇంకే ఉంటుంది. రైట్, దెన్ కమ్స్ ఏట్రియల్ మిక్సోమా, tumor blocks. The most common primary cardiac tumor is atrial myxoma. Most common site left atrium, originates from myxoma kada, mesenchymal cells. It is very much benign, but it can embolize, it can lead to obstruction at the level of the left atrial valve, atrioventricular valve, mitral valve. So it presents like mitral stenosis. And if the patient is upright, more block. Left lateral position, more block. So it is worse positional symptoms. And embolism can lead to CNS stroke, retinal artery occlusion. Worst is it presents with fever, weight loss, arthralgia. I can never forget the patient of left atrial myxoma. Fever of unknown origin. Weight loss అంటే మనకి టీవీ మందులు కొట్టిన అన్ని సచ్చే మందులు కొట్టిండ్రు.
So how can it present with fever, weight loss?
Because systemic inflammatory markers will increase in a myxoma.
Okay, sir. Okay.
Fever, weight loss, arthral చేస్తే వస్తే మనకి మొత్తం టీవీ మందులు కొడితే,
Yeah, we'll never think about it.
యాక్చువల్లీ ఒక ఫైనల్ ఇయర్ ఎంబీబీఎస్ స్టూడెంట్ ఉస్మానియా నుంచి వచ్చిండే, కెన్ దిస్ బి లెఫ్ట్ ఏట్రియల్ మిక్సోమా అని అడిగిండు. టుడీకో చెప్పిస్తే మిక్సోమా ఉండే. విశ్వనాథ్ ఆ పిల్లోడి పేరు. లేటర్ ఆన్ హీ డిడ్ కార్డియాలజీ. So the moments when our students outpace us, no, that is the time where we will feel happy about life. That's what any teacher want, right? So kabatti, remember doctor, feeling fatigue, feeling loaded, feeling anxious about outcome, they're all artificial feelings. The moment you think I can't, you can't. The moment I can, I only can in this entire world. And it is my one life opportunity. Just studying 100 days, I am able to make it to crack the exam. అనే క్రెడిట్ మళ్ళీ ఎవరికి మళ్ళీ రాదు లైఫ్లో. అండ్ దట్ ఇస్ ఓన్లీ క్రెడిట్ వీ నీడ్ టు లివ్ ఫర్. ఇన్ కేస్ ఆఫ్ మిథున, 10 days study. She will enter into her own Guinness Book record. I already entered her own Guinness Book. కాబట్టి హెడేక్ ఉంది, నేను లేవలేకపోయినా, నేను నిద్ర లేకపోయినా, ఆల్ దీస్ ఎలిబాయిస్ ఉన్నాయి కదా మిథున గారు, మీరు ఇవన్నీ పక్కన పెట్టాలండి. ఎందుకంటే వీఆర్ born, you are born to become. Hyderabad will be lucky if you become a gynecologist. I am telling you, 200%. What do you say? You
Yes,
concur with my? Huh?
Yes, sir.
Please meet your future employer. Future employer, when you can start your consultant practice. Good. So, doctor. అదన్నట్టు. సో అంతకంటే ఇందులో మజా ఏం లేదండి. మిగతా ఇది ఇంపార్టెంట్. కార్నీ కాంప్లెక్స్, స్పాటీ పిగ్మెంటేషన్, ఎండోక్రైన్ ట్యూమర్స్ విత్ ఏట్రియల్ మిక్సోమా. Together is called Carney complex. Typical patient is a woman, middle-aged woman, more than the prostatomegalic man. Now, what is chest X-ray finding? Left atrial enlargement, just like MS. With anta story MSA. Then, doctor, constrictive pericarditis. Imagine who is your patient. Ramaiya from Janagam with a huge ascitic belly walks into your OP. Everybody will jump and try to take a ascitic tap. First experience.
Yeah.
He will say enough of this thing. Every time it is coming out transudate only, not an exudate. Right? But his jugular vein is prominent, not collapsing with respiration. And when you took an X-ray, you found the old scars of the calcified areas of the TB in the lung. Ramaya said, TB bimari bahut zamane mein aaya. So that TB bimari has caused constrictive pericarditis. Whenever constrictive pericarditis is there, jugular vein is unable to drain. IVC is unable to drain into the heart. Hepatic vein is unable to drain into IVC, and that lead to development of ascites. So the non-GI cause of the ascites is constrictive pericarditis, the most common cause being TB. If the options are having TB is the answer. If you don't answer, you're not living in India. Now, what is the main mechanism? Impaired diastolic filling occur ultimately. Right? The most common symptom, there is a fatigue. Because if the filling doesn't occur, pumping doesn't occur. There's a JVP, ascites, pedal edema, heart hepatomegaly, etc., etc. JVP remains risen in the inspiration. And how do you know? Pericardial knock, which is a early diastolic sound after S2. Why pericardial knock? There is a tough sheet of pericardium around the heart, and when the diastole, heart is getting filled, ventricle is getting filled, it is expanding and hitting the thick pericardium. That is the underlying cause. Cardiac tamponade mein hoga, pulsus paradoxus. Kabhi constrictive pericarditis mein nahi hoga. That is a differentiator. గుర్తుపెట్టుకోండి. Pulsus paradoxus with that exaggerated movement of the interventricular septum at the time of inspiration అంత ఉంటుంది కదా సోది, అంత tamponade.
Like heart sounds are heard, but pulses are not felt.
అది pulsus paradoxus.
muffled
అవును,
sounds.
అంతేగా,
Ante sir.
అంతే.
Pulse is felt, but
Pulse is absent.
sir, heart sounds muffled ఉంటాయి.
మఫల్డ్ వేరు. అబ్బా, కార్డియాక్ అవుట్పుట్ తగ్గిపోతుంది కదా పల్సస్ పారాడాక్సస్ లా.
అవును.
అప్పుడు దాంట్లో ఏమైతుంది, ఎంత తగ్గిపోతుంది అంటే ఇట్ బికమ్ మోర్ దెన్ 10 millimeters mercury, you can't feel the pulse. But if you put strength, muffled but is heard. No, you're getting genuine doubts. Please continue. Continue thinking. Then what is meant by Frederick sign? Rapid Y descent on JVP. Absent Y descent is a feature of
Tamponade.
tamponade. Mirror ఫోకమ్ కాదు ఇప్పుడు చెప్పుకున్నాం
Yeah,
కదా
yeah, tamper.
యాక్సెంట్ బైఫిడ్ పల్స్ ఫోకమ్, డబుల్ ఎపైకల్ బీట్ ఫోకమ్. No worries.
Okay, HOC.
Now, if you do CT or MRI, you can demonstrate that pericardial calcification and thickening, right?
Yeah.
And that calcified pericardium around the heart looks like an eggshell, right?
Yeah.
Then, very common differentiation. If the myocardium is infiltrated with amyloid and other things,
Yeah.
it can lead to restrictive cardiomyopathy. There also heart is not able to fill. If the thick pericardium is there, there also you can't get filled. How to differentiate restrictive cardiomyopathy from constrictive pericarditis? Do the BNP, pro-BNP level. It is much, much higher if it is a restrictive cardiomyopathy. And if you do cardiac catheterization, what do you get? Equal diastolic pressures is the classical thing, and you treat by surgical pericardiectomy, nikal do unko. And because there is all congestion in the right systemic circulation, right heart
Yes.
side, diuretics.
Okay.
అయిపోయింది. అబ్బా గుడ్. ఎన్నో పేజీలో ఉన్నాం మీకు?
50, 40.
49.
50.
ఇంకా
1/3 डाउनलोड ओवर, 33%. बाद में शुगर बिगर वो सब क्या है, फटाफट कर सकते. My promise is I'll do revision before Friday.
okay, sir.
మెడిసిన్ భూల్ జాओ.
Yeah,
Thank you.
You only listen to me.
yes, sir.
రిమైనింగ్ మీరు ఏం చేస్తా చేయండి.
Okay.
థ్యాంక్ యూ.
Yeah.